This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. So welcome everybody to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. I'm a MedPeds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We have been coming at you since October of 2016 with episodes that vary on topics related to pediatric hospital medicine. Today we are doing a very special episode. For those of you who are new to us, please remember that the University of Pittsburgh gives free CME to anyone who listens. Just click on a link at the bottom of the podcast description. It'll take you to the University of Pittsburgh site. You make a free login, answer a couple questions that I write, and you can get free AMA Category 1 CME credit for this. This is a hot topic. It's fresh off the presses. You've been seeing it in the news everywhere, and we're going to talk about it as best we can with the information that is available on vaping related lung injury. That's right, we're talking about vaping. Now, to talk about it, I am very fortunate to have our special guest today, Dr. Joshua Shulman. Dr. Shulman went to medical school at the University of Pittsburgh and then did an emergency medicine residency at the University of Pittsburgh and did his medical toxicology fellowship at the University of Pittsburgh as well. He's currently an assistant professor of emergency medicine and assistant professor of rehabilitation science and technology. He works as an emergency medicine department attending physician and as an attending physician in the Division of Toxicology. So I couldn't think of anybody better to bring on to talk about this. So Josh, thank you very much for joining us.
Thanks for having me, Tony.
All right. So this has been everywhere, and we're seeing it, everyone's seeing it. It's a hot topic. Can you just talk a little bit about what is vaping, a little bit of a background for those people who may not be as up to date on this?
Sure. Yeah. This is a new thing for me as well. I mean, from when I was, we've been discovering more and more people, telling us about this thing, and it's the first time I really ever felt old talking to these young kids about the vaping, and then I just feel like I'm geriatric all of a sudden. but yeah, this is a unique phenomenon because it's really young, healthy kids who are being exposed to this kind of new frontier of chemicals in a really unique delivery system that it's kind of popped up, and we're basically playing catch up. Trying to treat the consequences, but so in general, like vaping, I guess it's a really broad category that describes delivery of some kind of vapor, an aerosolized vapor that's usually made by heating up a liquid. Obviously, that's how vapor is made. And then it turns into inhalable vapor that you can take up into your lungs. And so the most commonly available things on the market now are nicotine vapor inhalation devices. These are, I remember hearing about these when I was a med student, and I was like, oh, that's a good idea for people who want to stop smoking. Put some nicotine in there, they don't have to do lozenges or patches, and it can even like replicate the hand-to-mouth kind of idea. And there's even FDA-approved devices like that. But what we're seeing now is more, it's kind of like the Wild West out there. There's less and less regulation governing it. And with the state legalization of THC, we're seeing more THC-containing vape products out there, even CBD, and things like butane, hash oil, BHO, or dabbing. We're seeing that as well. So really, it's kind of a small industry that kind of exploded all of a sudden, especially in younger, healthy people. Kind of a new frontier, if you will, for a new population of lung disease.
So if I'm understanding this right, is it safe to say that if I want to define e-cigarettes and vaping, same thing? One is not different than the other.
I mean, in general, I think it ain't cool to say, here's my e-cig,
Right.
And so there's like, I'm going to go vape is the parlance. But I think, in general, The devices, the legal terminology refers to them as e-cigarettes,
Okay.
but the idea of vaping, I think, is more, I guess you could, there's a whole bunch of things besides e-cigarettes out there. There's e-pipes and these big boxy devices, and there's really like a cottage industry around like customization, adjusting the flow, adjusting the temperature, adjusting how much nicotine you get per inhalation.
People are very creative.
Oh yeah.
Oh yeah. So basically, if I want to define this loosely, it's a device that allows users to aerosolize or vape liquid, which can contain nicotine or any other substance that they can put in, and are sometimes flavored. Is that fair?
I mean, yeah, I think the flavoring is an important thing to talk about for two reasons. One is because there's we know from looking at cigarettes that flavored cigarette products tend to skew more towards younger individuals, so it's a good marketing tactic. The other thing, that the toxicologic part of it, is a lot of the flavoring compounds. They're not just natural compounds. There are a lot of them are chemicals with their own products. I mean, one we know a lot about from the toxicology side of it is diacetyl. That's the compound that's implicated in things like popcorn worker's lung, which is a condition that affects people who work in popcorn factories. The buttered popcorn flavor, when it gets aerosolized, can cause a really destructive lung injury. And
they're using that in e-cigarettes,
among other things. Yeah, really, there's no limit to what you can add into there. Anything from natural things like the limonene, or the lemon, the natural lemon flavor, cinnamaldehyde, which gives you that cinnamon taste. Those are like kind of natural things we have more experience with, but really, like, we're finding things like heavy metal contamination. There's a lot of different compounds that we're finding, formaldehyde, acetaldehyde, a lot of weird contaminants.
And are these not things you see in traditional cigarettes because cigarettes are somewhat more regulated?
Such a good question. I mean, so the people are there's an argument out there that, well, at least you're not just inhaling pure smoke, and that's a fair point. Are vapes, quote unquote, safer than cigarettes? You could kind of make an argument you're not getting all the polyaromatic hydrocarbons and all the the carbonaceous material, but you're also getting like just crazy high amounts of other things that are just kind of added in willy-nilly without a lot of regulation. So, could that be contributing to what we're seeing, the injury? It's a possibility. It's hard to say.
That's fascinating. And one of the things I didn't know is that now vaping has overtaken traditional cigarettes in teenagers as the thing they prefer. Is that right?
I mean, yeah, it's one of my colleagues, my division chief, was telling me a story. His son's a high schooler, and in the old days, people used to go to the bathroom and smoke, and now they go to the bathroom and vape. So they call it the vaping room, the men's bathroom. But I think a lot of public media, public sentiment has turned against cigarettes as a cool thing to do. And people, the public health concerns are known, but then vaping kind of emerged as an alternative around 2014 is when we started to see it take off, and the graph is almost like a hockey stick graph. It just kind of turns up.
Is that right? So in 2014 it just shoots up in terms of
usage.
Yeah.
I mean, we see for over years from around 2001, just the rates of cigarette use amongst all age groups. All youth age groups decline, and then around 2014 we see this massive spike in vaping among those age groups. So.
Now you mentioned dabbing, and I did not know what dabbing was until I started researching this because, like you said, I mean, we're not the young crowd doing this at this point, so we have to learn as we go. Am I right that dabbing is consumption of cannabis, whereby cannabis concentrate is volatilized via an application to a hot platform like a holder, and the vapor is then passed through a water pipe? So basically, it's vaped marijuana.
Yeah, I mean that's a good way to think about it. You take like a bunch of marijuana, you put it in a column, and you extract the THC with something like butane, like a solvent, and then you heat whatever extract you get. The butane gets vaporized off, and you're left with this really concentrated THC oil, which has a high proportion of THC in it, which again, really isn't regulated very very well. So that's another thing which we're seeing out there. Vaporizing that liquid. So.
And when we're talking about vaping and the lung injury associated, we're talking about this cartridge-based device. So where these people are, these devices normally filled with nicotine salts to deliver an aerosol to the user, and this is typically a closed system. We were talking about this earlier, and what's happening is the system's closed and non-modifiable, but users can modify the liquid composition within the cartridge. That's what they're messing with. And the third and fourth generation refillable tank-based systems, users can enhance battery power and add any liquid they choose to the cartridge. And that's what you're saying is they're playing around with what they can put in, and then we're kind of seeing the results of it.
Yeah, I mean that's accurate. I mean, so the question is, for what we've been seeing in the people who are suffering from the lung injury, it's simply not your. And we don't receive any funding from any kind of tobacco companies, but the Juul devices, the more regulated ones that are put out there by tobacco companies to replace tobacco. But this is more, we see people who are doing the homebrew counterfeit stuff, who are kind of mass producing it, and that kind of makes sense with what we saw back in the summer of 2019 with this massive outbreak. Had a geographic and a temporal association that kind of said, somebody out there must be making big batches of this centrally and distribute them to a large population with who knows what in there. And then we subsequently kind of found out, had some hypothesis about what was being added that was causing the lung injury, which we'll kind of get to later. So,
when you mentioned like the brands that people have seen commercials for, like Juul, or see billboards for, have you noticed? And I guess we'll get to it, but you can talk about it now if you want. Have you noticed that like a Juul brand is safer than another brand, or is it that because you can modify it with whatever you want, it's kind of anybody's guess?
That's a good question. I haven't seen enough data to specifically say anything about the safety of Juuls. What they saw in those big case series that they published, like in the New England Journal, is that there was a high proportion of THC containing vapes, and so and a lot of them were thought to be counterfeit. So there were people basically refilling the empty vape cartridges with whatever they wanted, and that was associated with the lung injury. So. That's what I was kind of saying. I don't think I can speak to the safety of the Juuls. I'm just saying from the small observations we've made. I'm not trying to make any enemies here with the companies, but I'm saying.
And as far as we know, because I just got an AAP Smart Brief, there is no regulation to this. The House is now putting this aside till next year in terms of regulating this more. So this market isn't like the cigarette market. That's tightly regulated. Sure. It's kind of totally unregulated.
Yeah. I mean, again, there's laws really vary by state. 50 states, 50 laws about this. What's defined as an e-cigarette product, and what kind of regulations are out there about it. But yeah, as far as I know, again, not a legal expert, but there's no big legislation that kind of governs it. So as I said, it's really the Wild West for now. It's kind of a perfect market, for people who are trying to, market towards like a vulnerable population, like teenagers.
So now let's talk about the epidemiology of this outbreak that we talked about. So
Sure.
This summer, all of us have seen this. I mean, we have a number of cases in Pittsburgh, and you were involved. We were involved in cases together. But how big was this outbreak?
I mean, the scale of the outbreak, I think, we saw, as of November, we kind of had some evidence with the CDC, in conjunction with the CDC, that there were about 2,300 cases, about 2,300 cases reported nationwide, with 47 deaths reported in 25 states, which is startling. Yeah, I mean, we were involved together here in cases here in Pittsburgh. Every state kind of has its own kind of story about the outbreak that they saw. I mean, there's MMWRs from Wisconsin, Illinois, North Carolina, about just temporal and geographically associated cohorts that all kind of came around July, August 2019. So everybody was kind of seeing this simultaneously together. And it was one of those things where, truth time, like my first one I saw, I didn't recognize it until I was like retrospective, like, I guess that's what it was. It's kind of a hard diagnosis to make too. We'll talk about why, a little later, but it can kind of confound you from the first attempt. So the other thing is it's hard to really definitively say this is caused by vaping. So there, in terms of the case definitions, there's confirmed cases, probable cases. In general, the population they don't tend to just vape one thing, so it's really hard to kind of make a definitive exposure and say that's what caused this. But it's a striking disease process when you see it, and so it's a serious enough lung injury that everybody kind of stopped in their tracks and said, hey, this is weird. We're all seeing this together. What's going on? So that was again, it was a real kind of interesting case cohort that came through in those few months back there.
And what we were seeing from what I have here is the median age of the demographics. The median age was 19 years old. Most were male. About less than a third had asthma. Most had no medical history. And then all of them had used e-cigarettes within 90 days. And a lot had reported using marijuana or THC as the vaping product, something like 80% or so. Is that right?
Yeah, that was from the Wisconsin and Illinois cohort. It's actually a pretty interesting public health story where, in Wisconsin they saw a bunch of these cases all at once, and they put out a statement like, hey, we're seeing this. And then Illinois was like, hey, we're also seeing this. Somebody reached across the state border. So then the two departments of public health started working together, and they published this joint kind of cohort case series, and so that's a lot of that demographic information comes from that. But I think that kind of skews with what we're seeing in our population too. It tends to be younger people without really much in the way of lung disease. Definitely not the structural lung disease that you would expect when you see the kind of chest X-rays and CT scans they're presenting with. These really kind of gnarly looking, radiologic findings that you wouldn't expect in a person of that age with that kind of exposure. So that was kind of the really striking part for a lot of the observers. What
was the case definition that was being used to say, okay, we think this case is vaping-related lung injury?
Yeah, that's a good question. So so basically, you had to have exposure to some kind of vaping product, and again, this really wasn't secondhand exposure. So it was like primary, mainstream exposure to a vaping product in the past 90 days. And a lot of these people, weren't smoking, day 89, and then they did sell, 89 days ago, and then developed. This was like people who were smoking up until the time where they presented. Most of them had used in the past 7 days, and most were, a lot of them were heavy users. But they had to have also some radiologic findings consistent with vaping injury. So usually bilateral opacities, and to go further, like bilateral ground glass opacities were seen pretty much in all the reported findings. And then really no other reason for them to have those infiltrates. So no other infectious causes, no underlying lung disease that would give them those lesions. So basically, if you fit all three of those categories, you could be called a confirmed case. Now, say you had everything, but then you tested positive for flu, then you had all the other criteria, but they didn't think the flu was causing it. They could call you a probable case. So that was the kind of the differentiating factor with the epidemiologic description of that.
Now, have the amount of cases we're seeing dropped off? Are we out of the epidemic, or are we still right in the middle of it?
Hard to say. I mean, I think with the public knowledge of the vaping injury, theoretically the use has gone down. People are more cautious about what they're doing, what they're vaping. But I honestly, I haven't seen as many cases as we did in that one kind of couple July, August, into September. The number of cases we're seeing has really gone down, but hard to say if that's what's causing that. Whether it's that one central process that was putting out all the vapes with contaminant in them is shut down, or why that is. But honestly, the numbers that I've personally seen have gone down, but. We're still kind of. I think it's too early to say that we're out of the epidemic at this point, especially when we have like almost 2,300 cases nationwide. So
that's a fair bit. And did they find a specific one laboratory or something that was making these, or?
I mean, again, there's the news reports. There was a couple of individuals in Wisconsin. They were dubbing them the Walter White of vaping. It was kind of a homegrown operation where they were refilling old vape containers with THC vapes. I don't think they could definitively link them to the whole operation. But they did note a couple interesting things. One is that when they would confiscate a lot of the vapes that were associated with the lung injury. So previously, whenever people got sick, they would ask them, "Hey, can you bring in your cartridges? Can we test them?" They would collect samples, and they would also then go and get BAL specimens from individuals who came down with the illness, and both of those samples contain this contaminant called vitamin E acetate, which then became a hypothesis as to why this is happening. It was hypothesized that this was causing some of the injury. But again, I think it's still an association with the vitamin E acetate. There are a lot of samples without it. And really, there's a bunch. If you pathophysiology, maybe we're looking at a bunch of different illnesses that are all kind of going under the label of vaping associated lung injury.
What do you mean?
Well, so when you look at the CT findings, there's a couple different patterns we've been seeing, and it's been published in journals like the New England Journal of Medicine. Again, everybody has pretty much bilateral lung injury, but some people have more of a pattern you would see in like hypersensitivity pneumonitis, like an eosinophilic pattern, like something you would see from eosinophilic pneumonia. You see smooth septal thickening, and you would see maybe pleural involvement. I was looking during my review of the literature. I actually found a case out of Children's Hospital back in 2018 that one of our colleagues, Dr. Sommerfeld, had published that described this before the outbreak. This hypersensitivity lung pattern with the eosinophilia. So it was a nice kind of idea that this has been going on maybe longer than we've realized, and just took a really, burst of temporally and geographically associated cases that kind of bring it to the forefront. But maybe we've been seeing this for years, just didn't recognize it. So, but anyway, that pattern of eosinophilic predominant pattern usually is associated with a more sudden onset, quick onset of symptoms. We also see like an organizing pneumonia pattern where it may spare the periphery and you get more of a central lobular, maybe a nodular pattern. And then we're also seeing this lipoid pneumonia pattern, which kind of gives this kind of more diffuse, they call it like a crazy paving pattern, where you get some lobules of the lung affected and some right next door not, kind of all over the lung like that kind of dotted through. So really we're not just looking at one. Maybe not looking at one illness, maybe we're looking at a bunch of different illnesses. It kind of makes sense when you think about it because, there's thousands of different compounds in the vaping fluid, all different temperatures. It's kind of the vaping cartridge itself is like a little mini chemistry lab, so we don't have enough. There's a bunch of different exposures all at once, could be causing different lung injuries.
Then it depends, I guess, on, from what you're saying, who put what in the cartridge at what point, how high the temperature was for the battery, to tell you, or at least to understand why whatever lung injury you're seeing is occurring. Because what you're saying, there are three different injuries that could occur in someone with vaping-related lung injury. Mm-hmm. And are they seeing, can someone have two things at once, like the organizing pneumonia mm-hmm. and the eosinophilic pneumonia, or is it usually one thing that causes the respiratory failure?
I mean, it's interesting because it's an interesting question. I think when you look at the histology of it, I mean, a lot of the histology is kind of varied too. You're seeing one of the classic histologic findings they're reporting is these things called lipid-laden macrophages. They find this on like a red oil O stain. I don't profess to be a pathologist, but this is just what I've seen associated with it, and that's an interesting finding to find in a teenager with healthy lungs. So they were using that as kind of a marker of the injury, but they find that injury pattern in people with the eosinophilic predominant pneumonitis, as well as the lipoid pneumonitis. So it's really kind of it's hard to say. It's hard to kind of say, all three stay in their lanes all at once. You might see a kind of conglomeration of all three based on what's in the vape. It's really hard to say exactly what you'll find from what exposure. We haven't seen enough of it to be able to granularize it, saying, well, this vape would cause this injury only, not this injury. So,
and we should clarify. I mean, this is all new.
Right.
It all just really occurred. So the kind of deep randomized control trials that you would see to help define a disease and what can cause it just haven't had time to occur. So all this is on epidemiologic data.
Basically, yeah.
Retrospective reviews.
I mean, sort of like a lot of toxicology data. It's really hard to do random. It's really hard to convince a subject to say, here, vape this.
Vape this and see what happens.
See what happens.
That's a very good point. Ethically, that's a problem.
Yeah, I would say so.
All right, so the clinical presentation, this is going out to a lot of hospitals. People work in a hospital. What are they see? What are we seeing? What does the patient say to us that should make us think, oh, maybe this is a vaping-related lung injury?
Yeah, well, that's a good question. So a lot of times we're thinking vaping-related lung injury. They're probably come in with lung predominant findings, which a lot of them do. I mean, most in the cohorts that have been described complain of shortness of breath and cough as the most predominant findings. But one of the interesting thing is, about three quarters of them had been seen previously and then had been missed. So they're on at least their second evaluation was when it was diagnosed, and they were admitted to the hospital at that point. And so that's, it's very easy to kind of say, well, so you're coming in, so if you're telling me you're having shortness of breath and you're coughing and you're a teenager, that sounds like bronchitis. That sounds like, maybe atypical pneumonia, viral URI. It's really easy to kind of write that off. One of the interesting things is a lot of these individuals, they didn't have the rhinorrhea, the upper respiratory congestion, all the sinus issues you would expect from a viral URI. So that was one of the things they found differentiating between the typical infections you'd see in the population. And then the other thing is a lot of them had kind of constitutional symptoms out of proportion to the amount of coughing, fevers, chills, more than so you would expect from a typical bronchitis. And a lot of them, maybe anywhere between a half to three quarters, complained of nausea, vomiting, and diarrhea. Now, if you're saying, well, that sounds a lot like the flu, you'd be right. A lot of these are flu-like, symptoms, constitutional symptoms, kind of all could be, explained by a viral etiology. But then the striking thing about the population is that when you actually look at the radiographic imaging, you're like, wow, that looks really out of proportion for what I expect for what you're complaining of and the degree of
so then
illness.
When you see, we talked about the multiple infiltrates, but are you seeing like ARDS or severe lung disease?
It's really a spectrum. It goes anywhere from a mild oxygen requirement all the way to ARDS and needing V ECMO, which is
so because we're heading into flu season.
Sure.
I mean, flu's just hitting now. So what we're saying is fever, cough, chest pain, nausea, vomiting, diarrhea, some belly pain, which really is flu.
Sure.
But then if I have that patient, I'm getting imaging, especially if they're an older teenager, more likely if they're male, but women too. I'm gonna get a chest X-ray because if I see just kind of like patchy infiltrate like you expect with the flu, I'm okay with it. But if the kid seems sicker than I would expect, and then I see worse lung findings on X-ray, then I'm going to consider this as an option.
So I think the for my practice at least, I agree with you. I'm looking at this. If I'm seeing a kid like this in my emergency department, I'm thinking, it's the flu until proven otherwise, and that's the kind of the thing I want you to kind of go forward with. It is a diagnosis of exclusion. I wouldn't be saying, oh, this kid probably has vaping, lung injury. They should just go home. This kid may have, you would kind of want to exclude your infectious etiologies, your other etiologies first, but also I've started asking about vaping, with all the people I see with constitutional symptoms to kind of keep it in my mind as, constitutional respiratory symptoms or GI symptoms even, and a lot of them look at me funny, like, what's vaping? But every once in a while you get someone say, oh yeah, I vape, and so it kind of, I think it's a diagnosis you can really only make if you have a degree of suspicion for it, and you kind of elicit that history if it's there.
And we've had cases, and we can't give away too much because of HIPAA, obviously, but where the child didn't tell anybody until a friend came to visit him in the hospital in the ICU or something.
Sure.
And then the friend said, oh, we've all vaped.
Right.
And then all of a sudden it pops up. So this is something that, like everything else with teenagers, they just may not be telling their parents.
Sure. Yeah. Yeah, I agree. I mean, it's definitely a sensitive subject for some. Some people are, they don't want their family to find out, but they might think they're going to get in trouble. So it's definitely, something that has to be illicit, just like any kind of social history. If you can try to get the child, the individual, give them some privacy, give them some, try to normalize it as much as you can. Just say, look, this is something we're concerned about for your health, but we need to know about this so we can help treat you the best that we can. So.
Because this is so new, one of the areas that could be a little challenging is who kind of owns this in the hospital.
Sure.
What we've done, which I think we've done, and correct me if I'm wrong, is it's kind of a joint effort between pulmonary and toxicology in terms of who really owns this after the patient. Most of them have been in the ICU and have been very sick and intubated. Right. And that seems to be a nice model. Do you think, is that what's happening nationally? It's kind of a joint effort because there's a toxicology component, but someone's got to follow the kid's lungs and see how they recover.
Yeah. And that's a good question. I think it kind of depends, from institution to institution. Here, I mean, we're really appreciative of the critical care colleagues, pulmonology colleagues, and their expertise in dealing with this because, really, I mean, from the toxicology standpoint, there's not like an antidote or anything that we, offer, but it is, we kind of help. It looks like other things that we see from toxicological exposures, and so we can kind of offer that perspective, maybe differentiating it from other exposures, and giving some wraparound epidemiologic help with our poison centers, which we all here at Pittsburgh work with the Pittsburgh Poison Center, and so we're helping coordinate with the whole state of Pennsylvania and nationwide all the poison centers in reporting these vaping-associated injuries from the public health standpoint. So.
And are most of these kids so sick that they're getting intubated, or has that just been our specific experience?
I think the kids that get intubated, the healthy kids with healthy lungs, they kind of stick out in your mind. From the cohort, that was reported, it was really only maybe a quarter of the younger individuals that got intubated. When you look at the ones that were over 50, though, about 50% got intubated.
Over 50 years old.
But there was only a small number over 50 years old in that population. The median was closer to 19, 20 years old. Okay. So it was just striking, it makes sense, with, older individuals, more comorbidities, more likelihood for respiratory, for lower respiratory reserve. But so these are young, healthy people with healthy lungs. They have a lot of respiratory reserve, but they were reported anywhere between like 20 to 25% of this population getting intubated for this.
So it seemed like more empirically in my head, but you're right. Those patients must stick out, and the others that are on BiPAP and Define.
Yeah, or just someone on oxygen and they just got observed and they got started on steroids. So I saw the whole gamut basically.
So now we've talked about the clinical presentation, we've talked about the pathophysiology, we've kind of talked about there's a diagnosis of exclusion. Let's talk about the lab. So if I'm seeing this kid, if I'm seeing a child and I think that this could be vaping-related lung injury, what should I look for with labs?
Yeah. So I mean, sadly, there's no test for this. It kind of goes with the workup of any kind of lung injury. We're seeing most had a leukocytosis of some degree, greater than 11, with the median I think was around 15 for the cohort, the biggest cohort. A lot of them had elevated inflammatory markers as well. ESR and CRP was typically reported as elevated, but nothing really specific. Usually a lot of them didn't have an eosinophilia, even with the eosinophilic pattern. The one with the pulmonary or the pleural effusions didn't really have a high eosinophil percentage, and that would kind of help differentiate from other inflammatory pneumonitis. Some about half actually had a mild bump in the ALT and the AST, which is interesting, and again, hard to really kind of tell how that's working pathophysiologically, but just kind of an association that was noted.
So even the ones with this acute eosinophilic pneumonia pattern, when they did the radiology or even the pathology, they didn't have a high eosinophil count.
When they had the pathology, I believe they had eosinophils in the lung,
sure,
but in
peripherally,
not a lot of eosinophil yet. So
that's fascinating.
Yeah, so that was maybe that would be something to help differentiate, but again, this is based off of a small number of observations. So.
And we talked about the lipid-laden macrophages, that was something people saw, which is a little surprising. Mm-hmm. And then you don't necessarily have to bronch these patients.
So that's like a good. So I think a lot of initial bronch data is out there because critical care docs are like, oh, let's bronch it and see what's going on. But I think the more and more you get out there, the idea that everybody needs to be bronched for this is, as we start to understand what we're seeing here. Basically, you could say, well, only if there was, you wanted to, there was other diagnostic consideration, like some kind of, immunocompromised or some other kind of disease process going on that would need to be brought for that. Again, I don't want to tell a critical care doctor, or a pulmonologist you can't bronch a kid, but the saying, whether mandatory bronchs are needed on everybody, I think, we're going to be seeing a lot of the same, lipid-laden macrophages and a lot of neutrophils, but not, typically, the BAL specimens don't show infectious etiologies, and so unless you were specifically looking for an infectious etiology, otherwise, for some reason, that might be another reason to do a bronch. So.
And it made sense to do it more at first when this was first coming out, because we didn't really know what this was, so they had to do it. We talked about the radiologic patterns, which was the acute eosinophilic pneumonia predominant pattern, the organizing pneumonia predominant pattern, and the lipoid pneumonia predominant pattern. About 91% of kids who have this have an abnormal chest X-ray, and the ones who had a CT of the chest, all of them were abnormal CTs of the chest, which is amazing. And then, so what were you seeing on CT for the most part?
I mean, this would be a CT that the way I describe it is, when you're even if you're not a radiologist, you're looking through the CT and like, man, this looks bad.
I could do that.
Yeah,
exactly.
I could do that. Like, this don't look good. That's how I would describe the CT findings. So, there's a bunch of very good publications out there. A lot of good studies that show some findings, but typically, the findings you would see on the CT scan, bilateral infiltrates, kind of in all lobes, are tended to favor the lower lobes. Ground glass opacities would be the best way to describe the typical finding, and you see that in all three of those subtypes. It's just you see a little bit different, flavor to it. So
now treatment. Let's get into treatment a little bit. So what do we do to treat these patients?
So again, when you think about the outbreak that occurred in Wisconsin, Illinois, I think a lot of people were like, let's try everything. So a lot of them had gotten antibiotics at some point, and typically a lot of them were getting steroids, large amounts of steroids for long periods, typically longer than 7-day steroid bursts. And the question is, well, what's the right amount of steroids? And I don't think that question's been answered yet. I think a goal of at least 1 milligram per kilogram solumedrol per day is a good kind of guideline, based off of no real data, but that's kind of where I think a lot of the people landed for treatment. Some use up to 500 milligrams a day of solumedrol, just like really high doses, to kind of see if that can give any benefit. I think about half the kids showed some improvement after starting on steroids. The question of, did the antibiotics help or not? I mean, typically, I don't think they're really identifying bacterial pathogens, so it's hard to say that they're causing any benefit. It takes me back to the old days where everybody was like, Azithro is an anti-inflammatory. So maybe people who are on Z-Paks were getting some anti-inflammatory effects. Who knows? But as for the what are the steroids doing? I mean, you can make the argument they're quieting down the macrophages, or decreasing the amount of inflammation, the amount of inflammatory cells causing inflammatory problems in the lungs, and decreasing inflammation in general. A lot of hand waving as to what they're actually doing. But I think the biggest thing about treatment is just stopping the exposure, convincing these individuals to not vape anymore.
I guess my question to that is, and I don't know the answer to this, is how difficult is that? Do they need some sort of nicotine replacement,
right?
Like someone who smokes cigarettes who has to stop?
Yeah, and they may. I mean, they may need, some other, because they're getting, who knows how much nicotine. They may be addicted to nicotine and it may be really hard to stop. So, so switching them over to a patch or to a lozenge or some other kind of form of nicotine and saying, don't start smoking, instead, that would be even worse. But so, yeah, that is a consideration, where you may have to put, a teenager on some other kind of nicotine replacement if they really show signs of nicotine addiction.
Marijuana.
Or THC, habituation. So again, that would be a consideration you may have to address, depending on the use pattern. And some kids, some light users are like, I use socially with friends, they have no problems quitting. But some people who are using heavily, daily, constantly, basically, may really have some difficulty with just stopping.
It's fascinating. And this, like you said, this is the first thing in my career, and I guess yours as well, where we've had this brand new thing that nobody's ever seen. Measles made a comeback, but people saw measles. Sure. This is kind of a whole brand new thing, so we're all kind of experiencing it together. So whether there'll be like vaping 12-step programs or Vaping's Anonymous coming up to help these kids, it's a possibility.
Yeah, and again, it's become like a politically charged topic. I was just talking to one of the med students I was working with who was telling me that she was in D.C. kind of a little bit after this outbreak, and there were protests about the idea of vaping legislation. There was like, our vape, our vote, or we vape, we vote, or something like that. Yeah. And so people are like, very attached to the idea of vaping, and they don't want government intrusion. So it's becoming a charged topic, and I think the political ramifications are kind of interesting to look at too. But yeah, no, I agree. It's definitely something that's new. Again, case reports go back to basically, when vapes became available, you see some hypersensitivity pneumonitis and some lipoid pneumonia. But really, the striking thing was how many cases we're seeing all at once that kind of said, hey, something's going on here, something different, something big. So,
yeah, the increase is very interesting. We have a tradition on PHM from Pittsburgh where we do a corny joke.
Okay.
We try to with every podcast. So are you ready?
Oh, do I have to have the joke, or do you?
No, I'll give you the joke.
Because I have a joke too.
You do? Then you can do one afterwards.
Okay.
All right. How did the barber win the race?
How did the barber win the race? I don't know.
He knew a shortcut. You're up.
All right. Well, this is my 4-year-old's favorite joke right now. Is how did the astronaut hold up his pants?
I don't know.
With an asteroid belt. He cracks up when he tells that joke.
That's a good joke.
It's really good.
For a 4-year-old, that's a great joke.
Yeah, he's something. So.
Well, Josh, did we go over everything we wanted to go over? Is there anything we missed?
I think I guess I'd say two things. One is just how sick these kids can look, and just to keep a degree of suspicion out there for it, for vaping lung injury, and kind of because again, going forward, trying to get them to decrease their exposure, educate the population about the dangers of vaping, again, and is important. The other thing is a shout out to our poison centers who are collecting this data, and the CDC. If you are seeing cases, make sure you're reporting to the CDC. There are CDC reporting forms available online. Sometimes people will be like, this is pretty minor. I don't think this needs to be reported. But no, we need all the information we can get on this. So please, reach out to your poison center if you suspect you have a case of vaping lung injury. Submit the CDC reporting form, so we can kind of get a sense of how many people are out there being exposed to this, and find which products are causing the most harm.
So then, ideally, what we should get is we have the Wisconsin, Illinois cohort that a lot of this data came from. Mm-hmm. But with the CDC, we're collecting so much data, we may get a better, more national cohort in terms of how people are presenting, et cetera.
Yeah, no, I think that there's more publications that are going to come out of this, as we get bigger data sets and more, more definitive exposures. So you keep your eyes out there for more information about the larger data sets. But again, from the poison center level, we're getting we can kind of coordinate statewide and nationwide. And we partner with the CDC, so it kind of all goes into the same bucket, if you will. So again, if you have suspicion, reach out 24/7. You get a poison center, poison specialist, and they can usually they'll be able to refer it to a medical director, a toxicologist. So we're available to help kind of delineate these exposures.
That's great. We appreciate your help. Thanks, Josh. I really appreciate it. Thanks for coming on.
Thanks for having me. Yeah, thanks so much.
Now, I may bring you back when we learn more about this and or for other toxicology stuff. Would you like to come back on?
Definitely.
That'd be great. So thank you. I want to thank our special guest, Dr. Joshua Shulman, one more time. Thank you all for listening at home. Josh, thanks again.
Thank you, Tony.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at Tony, Tony.Tarchichi, Tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.